We've been in the Leong Center and in CHES, we've been having many close collaborations with our colleagues in the Dalla School of Public Health. Um Exhibit A is Dr. Arjuman Siddiqui, who's our inaugural Leong Chair in Child Health Policy. And today's speaker is coming from Dalla, where he does really interesting, innovative. This is a code of some sorts, or Flatus. So today's talk is going to be about a really important area of relevance to many of us, very methodologically oriented, about how we isolate risk factors when we think about multidimensional social risk. Our speaker is Ingrid Giesinger, who's a PhD candidate in the Dalla School of Public Health. She brings extensive practical and research experience to her research work, including roles with the British Civil Service, which probably needs a discussion of its own for an hour, and the New York City Department of Health, which is a separate 1 hour discussion. And she was a public school teacher in Ontario, which is very laudable. She holds a BSc from the University of Calgary and a Bachelor of Education from OISE here at U of T, and a Master's of Science in Social Epidemiology at UCL. Welcome to Sick Kids. Welcome to CHES. Looking forward to your talk.
Great. It's wonderful to be here today, and I look forward not just to the sharing my research with you, but conversation to follow the topics that I share today. I'd like to begin this afternoon to take a moment and personally acknowledge the lands in which we're gathered. We're here on the traditional ancestral lands of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. As both a scientist and an activist, I'm committed to learning about the Indigenous peoples who lived here and cared for these lands for many, many generations. I'd also like to express my dedication to support the ongoing struggle against the oppressive systems that have impacted Indigenous communities. This work is vital for advancing human rights, both locally and globally. Now, as was mentioned in the opening notes, a bit about my professional experience, and I'd like to go into a little bit more detail on this, just to provide some of the perspective and context for my work in health research. Teaching in an Ontario high school, inner city, is like the ultimate qualitative field study. The schools I was in, the schools themselves, were home to an incredibly diverse student population, encompassing a breadth of socioeconomic backgrounds, cultures, and experiences. As a teacher, you're immersed in the real world context and experience firsthand how external factors like poverty, family dynamics, and neighborhood impact the student as an individual and their learning and achievement. In the classroom, you learn the narrative and voice of students, how their lives have been shaped by this environment, and gain insight into their aspirations and their challenges. I'll often use the analogy of a backpack. As a teacher, understanding your students, who they are, and the complexity of what fills their backpack is critical to supporting their student success. Both my teacher training and time in the classroom have grounded the focus of my work in health research on equity and
Oh,
has
sorry,
provided a wider
we don't have this
understanding
remaining.
of how the social context and political context impact education, a fundamental social determinant. The other part of my professional journey that was mentioned this afternoon that I think is particularly relevant to the context of my talk is my work with the British Civil Service and the New York City Department of Health. In the UK, I worked closely with policy on the analytical side of policy development, considering the who, the what, the how, the cost, scope, and potential and real world impact of an implemented policy. In New York, I led mortality studies with the World Trade Center Health Registry. And as a component of this role, I led the data linkage to identify descendants in the population. It was in these roles that I really understood the value of data, decision making in the absence of data, and an awareness of the gaps in my traditional epidemiology training to navigate the challenges of modern public health. An understanding of data science is no longer optional. This is an essential skill for managing, analyzing, and interpreting the large-scale data that drives public health and health research. These skills enable better decision-making, more effective interventions, with the ultimate goal to improve health outcomes and health equity on a population level. And so when I returned to Dalla Lana to complete my doctoral training, it was critical to me that I build on this foundation in data science acquired informally in the workplace and integrated these perspectives that I mentioned, having gained from my days in the classroom. The Commission on the Social Determinants of Health formalized the conversation on social determinants and described the social determinants of health as the economic, environmental, political, social, and cultural factors across our society that shape health. These exist largely upstream and outside of the health system, and yet have a demonstrated impact on health and health equity. One of the approaches to explain the social gradient in health outcomes has focused largely on health behaviors. I think in part, our focus on health behaviors is because in public health, this gives us something to intervene on. This paper from 2010 is one of many of an era that examined the role of health behaviors in the association between socioeconomic position and health. In this study, they used repeated measures of adult health behaviors that were measured at various stages across the life course, rather than a single baseline assessment of health behaviors at study entry. When they accounted for the repeated measures of adult smoking, alcohol, physical activity, and diet, they explained 72% of the social gradient in mortality. But what this study did not consider is why is there a social gradient in these health behaviors in the first place? Borrowing from the words of one of my mentors, what about the underlying upstream causes of the causes? Around the same time as that paper was published, the Institute of Health Equity in England launched Fair Society, Healthy Lives, which is commonly referred to as the Marmot Review. This was a government conditioned strategic review of health inequalities in England, and within it, they included 6 policy recommendations to reduce health inequalities. Central to the review is a focus on the life course perspective. As shown in the depiction, disadvantage begins before birth and accumulates across the life course. To address health inequity, action must start before birth and continue through the early years. And for this reason, the Marmot Review identified a focus on childhood and giving each child the best start in life as the highest priority recommendation in the review. In this publication was conceived as a response to the previously mentioned paper. In this paper, they utilized life course data from the 1946 birth cohort to look at the underlying contribution of early life circumstances to adult smoking behavior and how this contributes to those observed social inequities in mortality. And what was found was that 47% of the social gradient in adult mortality could be explained by considering these early life circumstances. And nearly half of that 47% was occurring through the smoking behavior. The takeaway here is 2 things. 1, the early life circumstances matter. And 2, if we only focus on adult behaviors or anything that occurs downstream, we ignore the underlying socially patterned causes of those behaviors. Although the consideration of health inequalities are not new, there has been considerable growth in the field of social epidemiology since the late 1970s. I think the events of the past few years have really increased a broader societal awareness and understanding of social disparities. Health inequity is no longer a topic that sits within institutions. This public awareness and discussion has really helped push the conversation on equity back onto the agenda of government, agencies, and researchers. I think in the context of this room and in 2024, we can all agree that the social determinants matter. The social determinants are the fundamental causes of disease. They are shaped by our socioeconomic and political context. And when we consider looking at a health outcome, the social determinants are the implicit mechanism contributing to health, regardless of whether or not we're explicit in looking at inequity in outcomes. But what are these social determinants actually measuring? How do we go about capturing them in our data? Often we'll use a measure like income or education individually without thinking about what's behind that. What is it capturing? What are years of schooling as a variable? We will talk broadly about capturing socioeconomic status, but we don't typically measure broadly or consider wider measures to reflect this concept. As an example, I recently reviewed a paper, and in that paper, they included socioeconomic status in the title and it was referred to throughout the entire paper. But their only measure of socioeconomic status was a single measure of education some 20 years earlier. Does this single measure of education truly capture socioeconomic status? To add to this complexity, even if we were to consider these measures independently, we know they are not independent. This is another figure from the Marmot Review, and here they're highlighting the social gradient in education. These columns are showing school readiness by parental income quintile from lowest to highest. And on the far left, we can see, by age 3, differences in school readiness by parental income quintiles. I find this really striking, age 3. The average score of school readiness at age 3 is nearly twice as high among those in the highest income group compared to the lowest. I think even when we consider our own experience, we can think and understand how our own educational attainment has an association with later life occupation and income. And yet we see a gradient or attainment gap in indicators of school readiness by early life income as early as age 3. For me, one of the reasons I think so much about education, in addition to being a former teacher, is that it's meant to be one of those universal experiences. In Ontario, from K to 12, we have a government-funded educational program with a universal curriculum. K to 12, age 4 to 18, or early adulthood. And yet, we can see already a gradient or attainment gap in indicators of school readiness by income in the household at age 3, before school entry. Now, nothing that I've said so far is novel. It's understood that the social determinants are interconnected and that together they influence health outcomes in complex ways. But our dominant framework is still to consider the influence of a single social determinant independently and isolate this. I refer to this as the single risk framework, and I believe that this approach is insufficient. When we focus on a single social determinant, we ignore this complex interplay between individual, area level, or community factors. It's a narrow approach that misses the dynamic nature of social determinants over the life course. And I think that this approach can hinder our understanding of how health disparities arise together and may limit our ability to develop effective interventions with a focus on health equity. While the Commission on the Social Determinants of Health shaped our understanding of social factors and how they influence health, we've since had advancements in data linkage, and analytical methods that have evolved significantly. Yet our approach to using these measures of social determinants has not kept pace with these changes. And so, largely motivated by my observations and experience as a teacher and later in government, the aim of my research is to explore how we can develop a comprehensive measure of multiple social determinants of health. A multidimensional approach to social determinants of health provides a comprehensive view of the complex, interconnected factors shaping health, enabling more effective interventions, targeted policies, and a deeper understanding of how systemic inequities may arise with a focus to promote health equity. Conceptually, I think a multidimensional social risk measure is similar to a concept of multimorbidity in chronic disease research. Multimorbidity, the co-occurrence of 2 or more chronic conditions, has a compounding effect on an individual's health. Multimorbidity also has an increased prevalence among those with social disadvantage across multiple ways of measuring the social determinants. Capturing multidimensional social risk of multimorbidity enables us to capture the broader context in which chronic conditions may arise and how inequities in multimorbidity may develop. So my research focuses largely on how we consider the social determinants in health and to explore multidimensional social risk within an individual. I've used several approaches to capture total social risk for Ontarians, which I'm going to share more about today. To understand the functionality of these measures, I've looked at the association between these developed social risk measures with incident multimorbidity. And so over the next few slides, I'm going to share a few ways to capture total social exposure and show how these measures are associated with multimorbidity. The study population that I'm using is formed using 6 cycles of the Canadian Community Health Survey. The Canadian Community Health Survey, or the CCHS, was linked to area-level measures from the Canadian Census, along with Ontario Health Administrative data, which is held at ICES. I've used the CCHS and census data to generate a social risk measure, and then we use the linked administrative health data to capture multimorbidity. Conceptually, each individual social determinant can be perceived on a scale from disadvantaged to advantaged or privileged. Each of these measures, education, income, place of birth, is filled with nuance. In our data, we, as an analyst or researcher, get to set a point at which we say this is socially disadvantaged and this is not. And this decision point may change over time and over place. For example, with education, for those born in 1930s, it might not be a disadvantage to only have elementary school level education. However, a student born in the year 2000 would most certainly experience disadvantage if this was the case. I've narrowed down a list of social determinants here from the CCHS. I've operationalized each of these determinants that you see on the slide as a binary measure where 1 reflects disadvantage and 0 reflects the more advantaged experience across each of these measures. Here, I'm sharing the proportion experiencing social disadvantage across each indicator among females and males. And I think this is one of the few slides that I will share today that really highlights the importance of considering the social determinants separately for each sex, given the observed differences among males and females, especially among measures like work history or income, among others. The first method I applied to summarize social risk is an additive approach. In this approach, multiple social determinants are collapsed into a continuous measure. This is done first by collapsing, as I've said, each social determinant into a binary measure where 1 reflects disadvantage and 0 reflects the more advantaged experience across each of these measures. Then, these indicators are simply summed together to create a summary score of social exposure. This is a really simple and crude approach, and it's applying and assuming that each determinant is carrying equal weight, which is likely not true. The second method that I'm using introduces simple weighting. In this approach, the binary indicators are summed within a domain. Then, each domain reflects an aspect of social risk, which is informed by the conceptual frameworks for the social determinants of health. And then we simply sum these domains together to create a summary score, so that now each domain is contributing equal weight to an overall social risk measure. To ease interpretation, the additive and weighted social risk measures were then categorized into 4 groups. So on this slide, I'm sharing results for the additive measure. These are radar charts that plot the proportion experiencing social disadvantage on the contributing social determinant indicators on the CCHS by these additive groupings. Now, if you recall, I've added together the social determinants. And so as we'd expect, in the most outer ring is the most social disadvantage across all of these indicators. This is highlighted here in green. Moving inward, we have purple and then yellow. But what I wasn't expecting was that blue, the group experiencing the least social disadvantage, would be absolutely absent from this plot. There were no immigrants in our group 1, no visible minorities. Everyone in group 1 was a homeowner, which was something that I perhaps should have been expecting, but was surprised to see. Now, the second part of my work focuses on applying these generated social risk measures to understand the association with multimorbidity. Here I'm sharing proportion plots, which are simply contrasting the proportion of the sample population and the proportion of the population with multimorbidity by each of these total social exposure group memberships. So as you can see in green on the top, among both males and females, individuals with the most social disadvantage have a disproportionate burden of multimorbidity. To evaluate the effect of each of these generated social risk measures on the incidence of multimorbidity, I've applied a competing risk survival model. The total social exposure measures are derived at the time of the CCHS interview. Then, through the linked data, we can identify when individuals were diagnosed with a chronic condition. Multimorbidity was defined as the presence of 2 or more of these conditions. To create a pseudo-healthy cohort, I've excluded those who were diagnosed with any of the chronic conditions of interest prior to the CCHS interview or within 1 year after the interview. So looking at plots of cumulative incidence, as we see in green, group 4 up at the top, is experiencing the most social disadvantage, also has a higher cumulative incidence compared to group 1 at the bottom, which has the least social disadvantage. And our plots are very similar when we look at, we see a same trend among both males and females using both the additive and the weightative approaches, with green at the top moving down through purple, then yellow, then blue, the least social disadvantage at the bottom. Looking at survival models, there's an observed social gradient in the unadjusted models under both the additive and weighted models. both among females and males. Contrasting females with the most social disadvantage, there's a slight attenuation in the weighted measure at 2.61 compared to those with the additive measure at 2.91. But we can see again that social gradient moving from top at group 4 to 3 to 1, and group 1 being our reference. And this is true again among both males and females with both of the approaches to measure total social exposure. Now, I've also adjusted for lifestyle risk factors, which include smoking, alcohol, physical activity, and BMI. And as we've talked about, there's some literature to indicate that these are actually on the causal path from social exposure to multimorbidity. However, they're also commonly adjusted for risk factors in chronic disease research, and so we've included them here. In addition to these health behaviors, I've also adjusted for hypertension and rurality. And when we adjust for these lifestyle factors in the weighted and additive social risk models, that social gradient that we talked about is still retained, even after adjusting for them. So the simple and additive weighted approaches that I've shared today demonstrate the risk of multimorbidity with this summary measure of total social risk. But they simply demonstrate that having more is worse without really talking about what's contributing to this. It doesn't talk about whether or not multiple social determinants are actually capturing multiple social things. Could this be unpacked into a few key things? Is this driven by one or two variables in this additive score? I'm going to share on the next part of my research, which is using unsupervised machine learning to look at total social exposure. Before I continue, though, I'd like to just highlight a key difference between supervised and unsupervised machine learning. Supervised learning is, I think, more commonly used in health research at this stage. In supervised machine learning, which is shown in blue on the blue side, there's a defined data label on our data set. An algorithm is going to use this label to improve performance on a task, like sorting fruit with the labels of apple, orange, or cherry. We then develop a predictive model, and we can apply this predictive model to a new piece of fruit to identify a label for this fruit with some level of certainty. In unsupervised machine learning, there is no label on the data. We don't provide categories for the algorithm to sort on. Instead, underlying structure of the data is used to extract meaningful features. So if we're looking at a basket of fruit, our features might be the color of the fruit skin, whether there's a leaf attached, a stem, the weight of the item. And then these features are used by the algorithm to inform groups. In unsupervised learning, we may get new, interesting, and informative groups, which we then can use our theory to apply labels to these groups. A key advantage is that it works well on new, unlabeled data. If we have a new basket of fruit, we can generate new categories based on similar features that we as a subject matter expert can then apply a label to. With the linked CCHS and census data, I have a comprehensive data set with over 40 measures of individual and area level social determinant indicators. This linked data set includes a vast number of variables, and many of them are interrelated. Through unsupervised learning, we can identify latent patterns in the data and form groups based on these patterns. We can think of each of these variables as a data dimension. And rather than clustering directly on this existing data, the first step is to reduce or transform the data. This data reduction filters out less relevant features, but it also increases the efficiency in problem solving for the algorithms. Then using this reduced data, we can apply a clustering algorithm to identify the patterns or groupings of similar data. What I'm sharing today is preliminary and in progress. Here, I'm sharing cluster visualizations that were generated using K-prototype, which is an algorithm, and it's applied to the reduced data. Here, I'm sharing a 10 cluster solution, which is what all of the subsequent slides are going to be based on. I want to say as well that 10 isn't necessarily the correct number of clusters in any given data set, and I'll talk a bit more about that at the end. So each dot that you see in these visualizations represents a person in my data set, keeping in mind that I start with around 40 dimensions, which we as humans can't actually visualize. So the clustering algorithm is applied to the data. Each individual in the data set receives an allocated cluster. And then I further reduce the data into 2 dimensions so that we can plot these cluster solutions and start to visually interpret what the clustering solution might look like. I'm sharing 2 approaches to doing this today. One is TS&E and the other is PCA. And the real highlight here is that it's important to look at different ways of doing this because they're doing different things as they consider the dimension reduction. They perform, both of these techniques do a different thing to when they're going through the reduction. So PCA is going to compress all of that information at the expense of variability, and ultimately taking the top two components, whereas TS&E is more about keeping like features close together, but it does this like at the for the balance of that is that the cluster distances aren't necessarily preserved. Hence why you sort of see more of a round spherical shape in the top. So then what we can do is start to look at who is in each of these clusters and start to identify patterns in the data. For the purposes of the presentation today, the message here is that there are different patterns of both individual and area level social determinants across these generated patterns or clusters. I don't want you to get out a magnifying glass and try to see what each of these actually means. In real high level, I've shown in green where clusters experience a value greater than 1 standard deviation away from the mean, so more to social disadvantage. And using that same metric, 1 standard deviation below the mean is in blue, so those experiencing less social disadvantage. And really, it's just that different patterns are emerging across each of these groups. We can then start to look more in detail at who is in each of these clusters and look for patterns. So on the next few plots, I'm going to share cluster membership by some of the social determinant indicators. In all plots here, all females are plotted in orange and all males are in blue. There is both a point and a labeled cluster number in the plot. Here I'm showing again the proportion that's not working and the proportion with limited education. And I think as hopefully you can see, the orange plot and the blue clusters are quite separated on when we plot them out. And to me, this is another one of those reasons. It just demonstrates how important it is to consider the social determinants sex stratified. On this slide, I'm showing population density per square kilometer, along with the proportion experiencing history of immigration in each of these clusters. At the top right, we start to see 0 and 9 among females and males, with being a high proportion of immigration history and living in a very dense population. Again, the takeaway from this is that these groups are looking quite different from each other as we plot them out. In the next two slides, I'm sharing the proportion racial minority across the x-axis, and on the first one, I'm going to show home ownership. So we have the proportion not a homeowner shown here. And again, on the top right, you can see a cluster for both females and males that is coming out with a high proportion racial minority and a high proportion not a homeowner. Similarly, down at the bottom, we can see still a high proportion of racial minority, but now this is a group that is largely or has a substantial amount more home ownership within it. I've also shared here the proportion racialized and the proportion living under the low income cutoff. So this is, again, look at the top right, we see two clusters among females and males with a high proportion racial minority and a high proportion living under the low income cutoff. Contrast that to the proportion on the far, or the dots 4 and 6 on the top left, that are high proportion living under the low income cutoff, but having a much lower level or proportion of racial minority in that group. So again, take away that we start to see different things that come out of these groups when we look at the patterns. I want to briefly talk about a story of a few groups. As you can think about, I've done this work sex stratified, and there are 10 clusters that have come out. So rather than talk through all 20 of them, I've just picked out 3 to speak about really high level and briefly today. And again, highlighting that these are preliminary results that my committee has not yet seen. So sorry about that. Group on the far left, we have I've sort of like organized these such that among females and males on the far left, these are a more socially advantaged group. So among females, we have high education, high income, high residential stability. And then group 8, which is on the bottom for males, is high community belonging. They're a higher proportion of cohabiting members, high residential stability. So I like to think of these two as sort of our social advantage groups on the far left. Across the top, you'll see the first 2 groups for females have a similar average age at 34, and then a slightly older age group at average of 38. Not a real big difference, but a slight difference higher. Group 4 in the middle, this is a group that has lower education, lower income, experiencing more material and residential instability. And on the far right is a group that seems to be living in in an area with higher dependency. So this would mean a proportion of the population are older adults, the proportion of the population are receiving government benefits, but it's also an area that has low material deprivation and low barriers to housing. Across the bottom in males, we've talked a bit about that first group being sort of a more advantaged group. In the middle, we have a group that's experiencing social disadvantage across many domains, so both individual and area level. And on the far right at the bottom, with an average age of 36, is a group that is a higher proportion of immigrants and racial minorities. They're a group that, again, we saw on those plots, more likely to be living in crowded or as a renter or not a homeowner, lower income, and they're experiencing area level deprivation across material measures, income measures, have a high proportion of unemployment in the area, and a high proportion of English language learners. So the next step that I have talked about is to first generate these measures and then to start to look at what these clusters look like in a Cox proportional hazard model. And so we can look at the association with age to multimorbidity. So again, as I said, the first column there is our sort of more advantaged group, and I've set this as a reference. And what we start to see, the specifics, the numbers, the hazard ratios that are in there are going to change as I refine the analysis in the couple of months to follow. But what we see are different patterns are emerging the based on the groupings that we have. And so we can see a hazard ratio of around 3.4 for that female group experiencing disadvantage at the top. Similarly, a hazard ratio of around 3 for that group in the middle among males, group 6, relative to that reference group. And our group 0 over on the right, which is the one that had a slightly higher proportion of immigrants and racialized minorities, has a hazard ratio of 1.92. And the takeaway, again, is like these are not results that are ever going to make it into a paper, but we start to see something different happening across these groups. The unsupervised clusters reflect multiple dimensions of social risk within a single descriptive indicator, which I think is an advantage over a single risk factor approach. This is really a data-driven approach, and it requires a theoretical lens to interpret. And of course, there are limitations with this approach. It's an iterative process that relies on expert knowledge of a research team to identify just how many clusters is the right number of clusters. In unsupervised learning, there is no set number of clusters that necessarily emerges. It's a little bit of a back and forth process. The other piece is how do we interpret the generated clustering as well, which requires some nuance and some thinking across a research team. The work that I've shared today is currently in progress, but I can already start to see next steps that I'd like to explore. For example, I'd like to look at how social risk clustering will vary across Ontario health regions, just to understand at the population level how social risk clusters may vary geographically across the province. I also have a more complete set of data up to age 75, so age 20 to 75, and I'd like to look at age stratified cluster generation so that I can start to understand a little bit more about the multidimensional social exposure and how this may vary across age groups, and more importantly, to look at when we start to exclude based on having previous conditions, is there selection bias from a multidimensional lens? And finally, another piece that I can see as an extension to this work, I've generated these risk clusters for Ontario, but it's Canadian Community Health Survey. This data exists across the country, and so I think it would be quite interesting to understand how this clustering may vary across Canadian provinces, which may give some insight into those higher level social determinants, so the political, social, geographical regions and the influence of that on the clustering. Conceptually, we're increasingly recognizing the importance of considering the confluence of multiple social determinants, moving beyond a traditional framework of isolating the effect of a single social determinant given the interdependence across these measures. I think this focus makes sense when we needed to be mindful of statistical power in our analysis, and probably still does to many of you who may work with smaller data sets. But when we're working with large linked data sets and we can bring together multiple data sets in the era of big data, we can move beyond the traditional approach of isolating a singular risk. Together, this approach enables us to look at how the social determinants may act and interact, revealing complex cause-effect relationships that are maybe more reflective of the real-world experience for individuals. As I've said, this work was already begun when we consider multiple chronic conditions. My work is extending this to include the importance of considering a multidimensional perspective to the social determinants of health. So one application of this work, like when I first sought out to do this, I was really focused on that association with multimorbidity. But something that's come up as I've worked on this is really understanding and monitoring, or an application that I think would be really helpful, is understanding and monitoring inequities across services, access, or outcomes within our healthcare system. For example, understanding who is and who is not accessing a specific service from a multidimensional perspective may highlight inequities in that service. If we don't understand where the inequities are, when we go to consider a policy change or intervention, uh, if we understand where the inequities are, when we intervene, we have a better sense of where to address the inequities. I think we also could start to look at those upstream social determinants that might be contributing to these inequities and start to potentially identify interventions within the social determinants themselves. As I've discussed, many social determinants themselves can also be conceived as endpoints or outcomes, the causes of the causes. And for this reason, what I've shared today, I think could also be used to monitor access, services, and outcomes across a broader, broader determinant as well. In education, for example, we could look again from this multidimensional social risk perspective, who is enrolled in a specialized in-school program, or look at the inequity in assessment outcomes such as the EQAO, or differences in student census responses such as safety or belonging. The reason I think this matters, particularly for kids who are on the margins, is that our educational programs are in themselves an opportunity for intervention. A systematic process for monitoring inequities in education may help to identify ways to intervene on the intergenerational impacts of social disadvantage, to really give each child the best start in life. But we can't do this unless we understand where these differences are occurring and to whom. I want to highlight two programs that have a demonstrated effect on improving outcomes for kids. The Pathways to Education program was created to help high school students from disadvantaged backgrounds in Toronto. The program Pathways provides mentorship, tutoring, and incentives such as transit fare. I first became aware of Pathways to Education when I was a teacher, but I've often thought about the long-term effects of this program, particularly as I've moved into social epidemiology. Recently, through data linkage and a quasi-experimental design, the long-term effects of the program have been evaluated. In addition to an increase in high school graduation rates, participation in Pathways is also associated with higher post-secondary enrollment rates, higher employment rates, and higher annual earnings. Now, moving to opportunity is a second study I want to speak about briefly, which is operated out of multiple cities in the US. In the 1990s, families in high poverty housing were provided vouchers to move to low poverty neighborhoods. And what they found was that for children under 13, the move to a better neighborhood led to a substantial positive impact across higher college attendance, higher earnings, and better quality of life in adulthood. But for children over 13 at the time of the move, these effects were less positive and even negative. The younger the child was at the time of the move, the greater the long-term benefits, suggesting that the exposure to a better environment during early critical development years is key to better outcomes later in life. The results from both Pathways and Moving to Opportunities demonstrate the positive effect of an intervention for individuals experiencing disadvantage, reducing intergenerational poverty, and an improvement in both individual and societal outcomes. But importantly, both the Moving to Opportunity studies and Pathways required follow-up over decades to observe an effect. In fact, the interim MTO findings after only 10 years did not find any effect on the measures they set out to study, such as education, housing, and employment. And in the final report, as I've said, with over 20 years of follow-up, the results that they did see were only among individuals under 13, again suggesting that critical early years window. Now, the MTO study also found a positive impact on both physical and mental health, which was an unanticipated finding from the original study design. And I think this again highlights the need to think about the importance of broader social determinants on health outcomes. Again, going back to Pathways, a question that I have asked since I've moved from teaching into epidemiology is whether or not Pathways had a long-term lasting impact on health outcomes in the students that participated in the program. And through data linkage, I believe that's a next step that could be possible for that study or for that population. My research emphasizes the need for a more holistic approach to understanding the complex interactions of social determinants of health, enabling targeted interventions, better resource allocation, and cross-sector collaboration to address health inequities and improve health outcomes. By capturing synergistic effects of multiple social determinants, we can also enhance predictive analytics and more effectively evaluate policies. The results that I've shared today are not specific results for you to take away and act on. I'm not suggesting that you take your data and apply K-prototype and look for 10 clusters. And in fact, if you did that, I'd expect that the results you would find would look very different in your data. The takeaway that I would like to leave you with today is to consider how we can think more broadly about social determinants in our data. And from that, how we might be able to generate new insights about patterns in the population. A collaborative consideration of the multidimensional social risk may lead to new insights that we then can act on to advance health equity. A few selected references, and I'd like to take a second to just thank my supervisor, Dr. Laura Rosella, who I think is on the call, along with Arjun Siddiqui, who is a committee member, and my broader committee members and co-authors for their ongoing support and feedback. I'd also like to thank the Population Health Analytics Lab and acknowledge my funding for this work through the CIHR, AI for Public Health, and the Novo Nordisk Network for Healthy Populations. Thank you. Yeah, that's great. That's actually an index that I'm not immediately familiar with, so I probably should go back and have a look at that. Other indexes that exist, I think there's a few things that are different about, like if I contrast to that. So for example, like the on-march statistics or the IMD that comes out of the UK, those are both using primarily and only area level information, which here I'm using both individual and area level to generate an index. I'd have to look at the methodology for that one and what is used for that. I think, more generally, what I'm looking at are both like the first two measures that I talked about are really simple and crude approaches that can be done by anybody. We all can look at our data set, make a binary variable, have a short conversation with somebody who maybe has more background or knowledge in health equity to decide what those cut points are. But then, quite simply, you could start to build an indicator that is on a very simplistic scale. The multi-dimensional one developed using machine learning and clustering is far more complex, and you probably want to approach that from a different perspective and has a different application, I think, in that way. But I don't have a direct answer because I'm not sure, totally familiar. I'd have to go back and look at the data and method for that approach. Yeah.
Have a look. And thank you. Does someone have to, that's kind of related to my previous question and to your response, but does someone have to have access to ICS data, to CCHS, and to census to be able to use the work that you do? I mean, that's the advantage of having area level information, is that you can
start to look and bring that all together. I think the takeaway that I would say, and I don't know what the work is that you do, but is like there are a number of different ways that we can borrow from other fields to do exactly what I have done. And so, perhaps your data doesn't have, full access to say the CCHS or doesn't like you. I would advocate for not using, if you don't have ISIS data, then don't use ISIS data. Look at the data that you do have and think about ways that you can bring multiple dimensions together within that data, whether that's a simple additive score or are there ways that you can link the existing data that you have, perhaps it sounds like perhaps not given, the commentary that you've provided. I think it's more about just, the real takeaway that I would send with is go back and look at what you have and how can you bring that together to be more, even if we don't have the individual and area level, what insights can we gain by bringing these measures together and thinking about that in that way?
Okay. Hi, I'm Catherine. I'm a PhD student. I'm really lots of things to think about. First of all, thank you so much. I'm really curious about what your hypothesis is as to why sex as a biological indicator drives social disadvantage as opposed to gender as a social construct.
It's a great question. And the answer is we don't have gender in the data that I'm using, first and foremost. And so I would say that I'm using sex as a proxy to pick up some of those components of gender. I will also add that the CCHS has started to collect information on gender. And so, in the more recent cycles, I think it would be interesting to go back and start to look at, what does a difference in that way bring into it, or what does have that information and that data bring into the clustering? Yeah.
I guess as a follow-up, gender I agree you can use it. I think that's fair to use it that way. But I'm really curious, have you developed any hypotheses as to why actually sex may contribute? Because I feel like at this point in privileged social circles, sex maybe or gender maybe not matter as much anymore. I'm not sure, but I'm just curious if there is any argument from what you've found so far for sex,
I
or is it all driven by gender, you think?
Oh, I mean, that's a great question. And to be totally honest, I haven't spent a lot of time going back and thinking about that decision. For me coming in, it was important to start to look at things sex stratified or like just to stratify in the first place. And the available measure that I had was sex to do that. So um, there's definitely some work and thinking and conversations to be done. I'm going to just follow up on Arjuman's point as well, in that part of that initial decision to stratify the analysis is because of the outcome that I'm looking at as well, being multimorbidity, where there are known biological sex differences in the outcome. And so, as I said, coming in, it was important to me to start that way, and that was the variable that was available. Uh, but more to do.
Ingrid, are you able to take comments from online?
Yeah.
We can hear you. So go ahead.
Okay. Then I'm going to take the prerogative. I think my hand was up first as well. It's Astrid Gutman. I'm sorry I can't be there in person. And thank you for a great talk. Sorry.
No, sorry. I was just going to say, anyone else online that wants to ask questions,
I can see them here now,
Oh,
actually.
they're in
Yeah.
the back.
Yeah.
Okay.
Yeah, I think there are some other questions online. I have two kind of related comments that relate to some of the data that you used, and then just a sort of bigger implications one. So, and I don't know whether this is just a power thing, but I just noted that like you use immigration as kind of one big category. And I know in the CCHS, there's not a lot of nuance on it, but certainly at ICS, like we have the whole immigration data set and, the range of experience from somebody who comes as an economic migrant to an economic caregiver to a refugee, and within the refugee groups even. So just wondering about that. And as well, I know it's a very heavy lift in terms of the kind of partnerships that you need to do, but just wondering your thoughts on doing this work, but not doing work to identify those who are Indigenous, when you're working in the equity space.
Yeah, those are both really good points. So on immigration, I think I've also, like, as you say, the CCHS does not have great measures of immigration. And I know that at one point we talked about looking at wider linkage, and I could not tell you right here on the spot what the decision was for the direction that we chose. And I assume it has to do with the overlap between the CCHS, which picks up, all of the other social determinants as well, and that probably there isn't very much overlap between those that occur in the immigration file data and the CCHS. There is some nuance in the CCHS immigration variable, which starts to look at how long you've been in the country. And we've looked at that a little bit as well. It's just very high level in what I've shared today. Do you have a follow-up on that?
No, I mean, I'd probably just give a plug for the fact that the, IRCC data that are, if you are in the ICS space, the IRCC data have, are very detailed about what pathway you come under, and actually have level of education and, other pretty good
Yeah.
things at the time of arrival. So.
Yeah. And so on your second point about, and I don't know that I fully captured or recall what you had said about Indigenous populations. And the CCHS does not include individuals or does not survey individuals living on reservations. And so the work that or the results that I share today would be exclusive of those individuals. I've thought a lot about this in part because there are like the CCHS is a broad survey, but it's missing really important minority groups. And for research that's focusing on social determinants, to have those groups not included in this, what does that mean? And I think, for me coming in, this was about a test case for, can we do this? How does this work? And what are some pros and cons of the various ways that we can do this? And I think there's lots of opportunity for next step to start to look at, through partnerships or for others to take on that work who have work and experience in those groups, to start to look at what that might mean and what differences might exist. I've actually, yeah, I'll leave it there.
Yeah, no, that's fair enough. And then my other question is really, you're, I can't decide on this myself, but I sometimes worry as work gets more complex, sort of translating that to policy and programming gets even more challenging. And so I'm just wondering whether or not you've seen similar work that does get into, a much more complex way of looking at, social risk being well translated, like either from the UK or somewhere else, into ways in which policies get or programming is rolled out.
Yeah. So, I mean, one of the examples that I think about that I went pretty high level on one of my follow-up slides about monitoring inequities in the population. And so the piece that I think is like, this is a starting point, and maybe not with the CCHS necessarily, but if we have like data that comes from, say, a hospital or something on a smaller scale like that, we form these groups, we understand what these groups might look like in terms of their association with various outcomes, or maybe are not appearing in various services. But I think there's also an opportunity to use this as sort of like the first step. And then there's a descriptive piece or a qualitative piece that could come after. So here is a group of that is of interest. But to really get at the depth of what that might look like in terms of policy development, I think partnering that with qualitative research to have groups or have conversations with the people who may fit into one of those groups to understand on it, to enrich that, cluster experience a bit. Which again, not possible with what I've presented, but I think possible in the applications moving forward as well. Yeah.
Great, thank you very much.
Thank you.
Hi, thank you. My name is Luke, and I'm a research assistant. Thank you for the great talk. I have so many thoughts and questions, but I think I only have time to ask one. So for the, I wonder if the, like the unsupervised learning results, it's a great starting point for identifying patterns, but I wonder how much that actually shed light on the causal inference under the so-called cause underneath the causes, and that and sometimes I worry that a purely data-driven approach could be misleading because that's subjective to the idiosyncrasy of the data. I'm sure there are methods you can safeguard overfitting, but I wonder what's your insight on the next step towards causal inference?
Yeah, it's funny, as I've thought when I entered to start this work, I really, as I mentioned, focusing on that association to outcome. And as I've worked more through it, I think more and more the value of this is that descriptive element to understand, we have these groups, we see these patterns that exist, and understanding, from that perspective, rather than necessarily a causal inference perspective using these clusters, which is maybe underselling the third objective that I shared today. I think it's a good point generally when we think about the data that we're using as well, and the biases that may come in from using a really data-driven approach. It's part of the reason why we've stepped up to look at using a national survey data rather than just relying only on health administrative data, which has some of that, or is more likely to have prone to that biases around that the algorithm may pick up in based on who's in the data. So we have a better understanding of who's coming in the first place when we start to to generate these. On the causal inference piece is something that I have to think about a lot moving forward as well. Yeah.
Hi, may I ask a question? Hello, I suppose I can go ahead. Do I have a green light?
Yes, go ahead.
Okay. Hello, I'm Revan. I'm a developmental pediatrician, and I have worked a lot in child development, in early child development. So that's why I want to just share and maybe ask a few reflections about your presentation. Um, so, as far as I understand, you use the hospital level, the health-related data as an outcome measure, as per my understanding. So. Uh, uh, the, some of the measures related to the child can serve as a surrogate mm, for a social risk. So, for example, if a child under 5 dies in a family, then because mostly it's a preventable death, then it may like serve as a proxy for social risks. So, have you considered, or what do you think about using it that way? Because, as far as I understand, the exposures are coming entirely from the CHES, and I guess it's not the household level data, right? It's individual data.
Yeah.
So and there you cannot know whether a child has died or not died in a family. So what do you think about that? Because what you have presented it makes total sense to me as someone who is seeing that risk working on children. I mean, I can see how it affects children, small children especially.
Yeah, I mean, it's a great point and not one that we've explored at all, looking at any sort of indicators that come from that health administrative data that can, serve as proxies or insight into. Um, it's definitely something I think we can have a conversation about. I think, what I would say at this from a starting point to sort of, ground the work that I presented today is that this is what I'm hoping for that, by sharing this sort of discovery work that I've been working on, that it leads to questions that other people can then start to go, well, what about this? And how do you look at that? I don't know that it's something that I can take back in, certainly in my thesis timeline, but as I look at this and as I uncover it, every time I present the work, I end up with another list of things that I could possibly go off and look at afterwards and see how that might feed into it and improve what I'm doing. Yeah.
Uh, so I'm not sure. Just didn't hear some of the questions that were asked here. So there's a multidimensional poverty index. I guess it's called like that. So it's really similar to what you are doing, but it's just about poverty. But these are related things. So some of the dimensions of the poverty that were used to just create that index, they really make sense to the what you are doing, and so there's that. It might have some sense to look into what the dimensions of that index. For example, it's there. One of the
Hi,
dimensions is
sorry, I'm just gonna have to
undernourishment.
interrupt.
Okay,
Sorry, we're
okay,
run out
sorry.
of time. Sorry.
Yeah.
Yeah, thank you so much. I was going to ask you're thinking about applying, because a lot of the research you've done is on adult populations, but you're quite
Yeah.
probably passionate about children, and wondering what the similarity and differences might be when you're applying this to a child cohort.
Yeah, it's great. I think, there's obviously a lot of the indicators that you'd want to start to look at are coming from, the exposure and experience of the household. So, it probably goes back to my earlier work, which did look at sort of early childhood factors. And um, I don't know what the data would look like in a Canadian context for starting to get to that, but certainly, indicators around, that the household, what's the composition of the household and the parents' the income, education, and those kinds of measures. But it's not something that I've like other than the education context, it's not something that I've fully transitioned to thinking about. Yeah, but it would be exciting. Yeah.
There, just another huge thank you.
Thank you. Thanks for having me here.
There are no round next week.